Thank you again, Dean. So next up, we have our paired presentations on global neurosurgery and how this department participates in it. We'll start with one of our residents now at PGY5, Dr. Schupper. Graduated from Hopkins as an undergrad and completed his medical degree at UCSD before joining us. He's been a very prolific academic resident, publishing substantially across a number of different subspecialties, most notably in neuro-oncology and spine, and has, I believe, fully defected to spine surgery for his career, but has also sustained an interest in global neurosurgery and joined the Cornell group to head to Tanzania. So Alex, I'm going to turn it over to you to talk about your experiences in neurosurgery abroad.
Thank you, Dr. Morgenstern. Appreciate the kind intro. Let me share my screen. Just wanted to start off, I noticed that there are actually a fair number of neurosurgeons and orthopedic surgeons here from Tanzania, so I just wanted to start by offering a special welcome to all of our colleagues abroad. So today I'll be speaking about a unique opportunity I had starting last year in terms of establishing a scoliosis program in Tanzania. I have no relevant financial disclosures. So in thinking of how I wanted to organize this talk, I thought that it'd be most effective if we actually went backwards. In reflecting upon this experience, I thought I would start with the 6 tenets that I really identified as core values in terms of establishing a unique program that's very complex, like a scoliosis program in Sub-Saharan Africa. And over the course of this talk, I'll go through these tenets. The first, which pretty much goes without saying, is you have to identify an unmet need. Second, and I would argue probably most important, is identifying a local champion. Very important, of course, is highlighting barriers in terms of the needs that are present. And then what's really important, which I'll go into later, is developing within the local culture. And the important part of that is within. Be critical of outcomes and communicate the results. I think this is something that Dr. Hartle has really imparted great mentorship in this program, which I'll discuss. And then finally, the result should be to create an autonomous, sustainable ecosystem for success. And I just want to quickly delineate that this is not a medical mission. That what a medical mission often is, and not always, but in many cases, the physicians come in from abroad, they are able to participate in great cases, really help patients, and then it's kind of like a hiking mentality of leaving no trail, that after they've left, it hasn't really impacted the local ecosystem. And this is something that we really wanted to fight against. And hopefully I can convince you that we're really doing something a little bit different in Dar es Salaam. So to really understand what we're doing, you have to understand the background of where neurosurgery is in Sub-Saharan Africa. And it truly is considered a luxury, something that I didn't appreciate until my time abroad. If you look at the literature, distance and affordability are the 2 major issues. Surprisingly, less than 0.25% of people in this region of the world only have 2-hour access to a public facility that offers any type of neurosurgical care. And to put it in perspective, this compares to 93% in Eastern Europe and even more than that in North America. There are 7 countries in Sub-Saharan Africa with no neurosurgeons present. And then across this entire region, there's only 1 neurosurgeon per 6 million people. You can think of this as less than 2 neurosurgeons available for all of New York City. It's pretty stark when you think about it that way. And obviously, there are many unmet needs in terms of neurosurgical care, but some of the major areas to highlight are TBI, spinal cord injury, stroke care, of course, hydrocephalus, especially in the pediatric population, epilepsy, and a multitude of spine conditions, of which scoliosis is just one. To give you some background on Tanzania, Tanzania is actually a relatively large country. It's seeing here, and you may think looks kind of similar to Wisconsin. There's a population of now over 62 million in this year, with a GDP of only $71 billion, which calculates to around 3,300 per capita, which makes it the 163rd richest country. The national language is Swahili, though. When you go outside cities like Dar es Salaam, you'll notice that many people speak local tribal languages, but most Tanzanians are fluent in Swahili. They have an interesting government structure in that there's a unitary dominant party where there's a Muslim woman as overriding president who, in a very endearing way, the Tanzanians refer to as Mama, and have have unparalleled support throughout the country. The majority of the country is Christian, with a third practicing Islam. And then, not surprising, the majority of the country lives below the poverty line. Tanzania ranks 159 in the UN Human Development Index poverty score. A third of the population is malnourished, which is really important when we talk about scoliosis care. And 80% of the population participates in subsistence farming. This is defined as not when you're farming the land for profit, but really just to sustain your family's needs. In terms of sources for the economy, tourism is a major contributor of the economy to the economy there. As you would imagine, Mount Kilimanjaro, the beautiful island of Zanzibar, Serengeti National Park are major contributors and sources for the local economy, as well as agriculture, banking, and transportation. Now, Dar es Salaam, where we're located, it used to be the capital of the country, is no longer, as of the last couple of years. It means abode of peace in Arabic, and was founded in the mid-1800s by the Sultan of Zanzibar. It's the largest city in Tanzania in this region of East Africa with over 6 million people. And it's the financial hub of Tanzania. And importantly, from our standpoint, there's been no prior exposure to the surgical management of scoliosis. However, there is an infrastructure to establish a scoliosis program, which are two key points to why I believe this camp has had the success that it has. Now, I want to introduce Muhimbili Orthopedic Institute, where many of our attendees here practice. Muhimbili is a really special really special center in this part of the world. It's a specialized hospital for orthopedics, traumatology, and neurosurgery. To try to put in perspective that we can all grasp our heads around, imagine a hospital like HSS and the orthopedic focus there, coupled with a neurosurgically focused hospital like Barrow Neurological Institute, as well as a busy trauma center like LA County, all combined into one campus. That's really what you have with MOI. So it's really a special place. There are over 300 beds with a mix of private beds as well as government public beds. And it's the leading institution in Africa for orthopedic trauma and neurosurgical training. There you'll see the full gamut of neurosurgical procedures. They're very adept in terms of instrument spine. ETVs are very commonly performed on the PEDS population who suffer from hydrocephalus. Both open and endoscopic skull-based approaches are performed there, epilepsy surgery, oncology. And so this partnership was founded by Dr. Roger Hartle, who everyone here is very familiar with, the co-director of Ox Spine at New York Presbyterian, back in 2008 by founding the Weill Cornell Medicine Tanzania Neurosurgical Program. To date, there have been hundreds of neurosurgical cases performed on both the brain and spine, and a global neurosurgery fellowship has been established. The current fellow, Dr. Kadu here, is a Canadian-trained neurosurgeon who recently completed her neurosurgery spine fellowship at WashU and now is located in Tanzania. And there's a robust research pedigree that has developed from this program. So like I alluded to at the beginning of the talk, I really believe that identifying a local champion is the most important part of this. And fortunately, we have a few of these guys logged on today, but here you can see on the right is Anis Masawi. Anis came all the way from Kilimanjaro Christian Medical Center, which, as the name suggests, is up in the north in Kilimanjaro, to come down. He has a busy orthopedic spine practice there, but wants to establish scoliosis care up in Kilimanjaro, so he came to join us for the week. Here you can see in the middle picture with me is Dr. Bryce Macharo. Dr. Macharo is the first fellowship-trained pediatric orthopedic surgeon in the country, who really has been the local champion at MOI in terms of developing this program and providing scoliosis care for patients there. Here on my left, you can see Emson Sharima. Emson's a junior orthopedic surgery attending, who's really picked up a knack for scoliosis and deformity surgery. And then back here is Julie Woodfield. Dr. Woodfield was Dr. Hartle's Global Neurosurgery Fellow last year, who resides in the UK. Now I could spend over an hour talking about the unique barriers that this ecosystem presents, but just to highlight a few things, paint a picture of really what we're up against. So I think the biggest challenge, as you would imagine, is getting these children to a place like MOI. Well, it's pretty straightforward to send a kid to MOI who lives in Dar es Salaam, but for these kids who live in remote areas of the country, it's very challenging. And this is all thanks to Dr. Macharo, who spent countless hours on the phone and communicating with the children, their parents, the schools, and to set up transportation. It's not so easy to set up transportation across the country for a family who lives on less than $1 a day, as you would imagine. The reason this guy in the middle picture has such a puzzling look, and I actually shared the same expression he had at the time, is When he pulled up the imaging of his daughter's spine, which you can very obviously see the curve here, he brought up a piece of paper and then said, "Don't worry, we're just measuring the Cobb angle." And so right after this picture was taken, he took a protractor out of his white coat and started measuring. And it really painted a picture for me of how we're going to get the job done. And for the seasoned spine surgeons in the room, you'll appreciate that these trays are about 80% empty when it comes to what you need to perform a scoliosis correction. And to say we were limited in terms of instrumentation is really an understatement. Coming from a place like New York City, I really took for granted everything we have here, from things as simple as SPD and the ability to have pre-packaged sterilized equipment. Is really something that we take for granted. So here you can see, it's really hard to see with the fogged up window, but there are a few very hardworking ladies in here that their job is to pack the gauze and to start sterilizing them so they could be ready for the operating room. Now, on the second day, after we came into Moy from the hotel, we were told by one of the head OR nurses that there was no ward today in the hospital. And so which I chuckled. I said, "How are we going to perform surgery when there's no ward in the hospital?" And to which he responded, "No ward, no problem." And so he spent the next 10 minutes after we had prepped our patient, grabbing water bottles, and you can see soap in one hand and water in the other. And he waited to scrub us all in, and we found a way. So it's just a tribute to the type of resilience that they have at a center like Moy. So going back to junior residency, thinking about the preoperative planning checklist, right? Everything you need in terms of starting a case and getting into the room, just to highlight some differences that you guys will immediately note. So in terms of imaging, obviously there are no computers in the operating room, in this operating suite. So you have to go to the administration office, print out any pictures you want, measure all your Cobb angles with your protractor, and have all your corrections up on the wall before you get started. There's a very limited supply of things as simple as antibiotics. So you have to be very judicious about how you're using all these medications. I think one of the biggest shocks to me was hemostasis and blood loss. And this is one of the challenges that Moy came to us at the beginning saying, "How are you going to perform these big surgeries when really hemostasis is a big concern?" They do have blood at the hospital. However, this is a very busy trauma hospital, and the hospital really doesn't want to use their very limited blood supply on your elective cases. So you have to be very mindful about that. And if we needed blood, it would actually take a pretty long amount of time to get it. Things like TXA Cell Saver are a dream that people at Moy had never heard of in terms of Cell Saver, especially when I almost jokingly, tongue-in-cheek, asked if there was Surgifoam, and to which they responded, "What's Surgifoam?" So I very quickly had my answer there. Things as simple as a bovie are all reusable there. Towels, gowns, etc. Everything gets reused. After my first case, I reflexively threw the towel that I washed my hands with in the trash, and the nurse very politely told me that wasn't going to fly here. And then I think one of the eye-opening moments for me was during our fourth day. This young gentleman here, who was a anesthesia resident, tapped me on the shoulder while we were putting in thoracic pedicle screws and told me, "Sir, I'm lowering the patient's head." To which I responded, "Hold on, give me a sec. We're in the middle of putting in a screw." And he said, "No, I'm lowering the patient's head." Kind of irritated, I looked up for a second, saw that the patient's blood pressure was 40/20, and they're about to code. So, fortunately, we were able to pack the wound and stabilize the patient, but it really gave me some perspective as far as things as simple that we take for granted here as fluid resuscitation is something that can be totally out of scope for unprepared trainees that just aren't used to these cases. And then things are a little bit more straightforward, but in terms of instrumentation, everything gets sterilized right before the case, and obviously you only have one of everything, so definitely don't drop it. Things that we take for granted here, like performing osteotomies, there's no Kerisons, Lexels, Midas Rex, absolutely not. So you have osteotome. So as much as you can use your osteotome, that's how you're going to do your osteotomies here. I think Edwin, who was our neuroelectrophysiologist from Kenya, was one of our heroes of the trip. I'm not sure, Sadat University, if you're still looking for more electrophysiologists, but this guy can keep up with any of them. And he really did a fantastic job stimulating all our screws, running great motors, SSCPs. There was really no lack of ability to monitor when we were there, which was a joy to have. In terms of sterility, so after the first case, or toward the end of the first case, after all of our instrumentation was in, I saw a mosquito circle around my face and land right on top of a screw head, to which I freaked out, and Dr. Macharo, who was standing right next to me, just chuckled and moved his hand along and brought the mosquito out of the wound, and told me, "Don't worry, sir, all these flies are sterile." So it really gave me some perspective. So needless to say, there were a lot of Capell and Caridi betadine baths that were going on. But I thought something that was really interesting that the surgeons in Tanzania told me about is that these kids really don't get infected. That from a young age, these kids just live with mosquitoes and other bugs all around them, and they build up such a tolerance and such an immune system that they have to undergo surgery that the rates of infection are incredibly low. It's something they almost never see, which I thought was really interesting. These children all went to the ICU post-op, as you expect, for strict MAP goals, neurochecks, and I think one of the things that you guys will see is how resilient these children are. That this young gentleman here, which was one of our cases, was out of bed only a couple hours after a large T2 to L2 instrument fusion. You know, believe me, he still has a central line here in his neck. So one of the important things is really understanding the culture, and this is something that Dr. Macharo and the other surgeons there really did a great job. They truly opened their arms up, took us in, and just the deep passion for learning and discovery was incredible. Here you can see in the top left, this is the daily orthopedic surgery grand rounds, which the neurosurgery residents also participate in. We had daily lectures there talking about scoliosis management, both operative and non-operative management. One of the customs that, if you guys know me, you know my love for eating before and after cases. So it didn't take much for me to get used to the fact that the OR staff prepares delicious meals for you before and after every case. And this wasn't because we're anything special. This is what they do for all the surgeons, all the OR nurses and techs, which is really a beautiful part of the culture. Something that I didn't appreciate until I was in Tanzania and we were performing surgeries is the importance to communicate our results, both locally and abroad. And this is something that Dr. Allen and Dr. Balsano, the two gentlemen here who really led this effort, really expressed to me, is that you don't want to be mercenaries and come in, do the surgeries and leave. You want to make sure it's known broadly what's going on, why you're there, what your purpose is. And so we communicated every day. We had meetings. We had meetings with the director of neurosurgery, director of orthopedics, the director of the hospital. So everyone understood the surgeries that we were doing. They knew the kids we were operating on. I think what's even more important than having guys that look like this in front of the camera are guys that look like Dr. Macharo, local guys who grew up in the region, who everyone knows who he is. They know his children, and they really trust him. And to establish a culture here that, hey, we're doing something that's more than these couple surgeries we're performing. We're establishing an ecosystem for scoliosis, and scoliosis no longer has to be a death sentence, that we send these kids home with no treatment option, that really we're providing these children with a unique opportunity that previously wasn't present. And something that's truly a testament to Roger Hartle, Dr. Ahmed, Dr. Balsano, and all of Dr. Hartle's past fellows is just how well they've been able to articulate these results. And a lot of this is a tribute to the local surgeons in Tanzania. As you'll see, a lot of these authors are all Tanzanian surgeons who have contributed extensively to reputable journals, JNS, the Red Journal, etc. Every journal in neurosurgery. They've published about 40 publications to date since the inception of this program. And you see, as you can see here, they've published on everything from spine trauma, infantile hydrocephalus, traumatic brain injury, and we've recently published on scoliosis. I just want to include one of my favorite publications of Dr. Hartle's, which is his case series on traumatic spinal cord injury following falls from coconut trees. Something that I alluded to previously is the necessity to create autonomy, that it's really not about is watching Dr. Ahmed perform awesome osteotomies and putting in really difficult concave screws across a significant deformity, but really instilling ownership over these guys. And the truth is, Dr. Macharo and Sharima, et cetera, they're all very good at putting in pedicle screws and understanding traumatic spine and degen spine requiring instrumentation. So they all have the groundwork to really be fantastic scoliosis surgeons. It just takes the expertise of guys like Dr. Ahmed, who you can see here, in showing them really the niche components of this type of surgery. Here you can see Dr. Macharo here lecturing on scoliosis care and really us guiding each other through a surgery, which was truly a special moment. Now, I don't want to go too in the weeds and as far as measurement, correction, et cetera, of some of these cases, but I just want to paint a flavor for the types of cases we saw when we were in Tanzania, because I think it will really surprise you. So this was a trip that we participated in back in April of last year. Over the course of the year, we screened over 110 patients. This was primarily led, this effort, by Dr. Bryson Macharo. We ended up seeing around 30 pediatric patients in the clinic, and from this, we selected 5 cases that were all relatively straightforward adolescent idiopathic scoliosis cases. These were either flexible or semi-rigid curves that we knew that we could accomplish an adequate correction through lower grade osteotomies. We excluded all congenital and neuromuscular cases, and I'll talk about why in a few minutes. Of our cases, the average age was 16. The majority of patients have flexible curves, with only one having a semi-rigid curve. I won't spend time going into the Lenke classification, but these are all Lenke 1 or 3 curves. All patients had Schwab osteotomies. The majority of patients just had inferior fascectomies or Schwab grade 1 osteotomies, with only 2 patients needing full Ponzi osteotomies. Thoracic curves were significantly corrected down to under 40 degrees. Lumbar curves corrected down to an average of 13 degrees. And the central sacral vertical line, or marker of coronal alignment and balance, improved from 4.5 to less than 2 centimeters. So just to give you guys an example of what some of these cases look like. So this is the first case. You saw her puzzled dad in the earlier photo, who had a flexible thoracic curve, but a relatively rigid lumbar curve here. And here you can see the decompensation and her hip tilt here. We were able to do a T5 to L3 instrument fusion, and she did great. She had relatively overbearing parents who were a little hesitant to get her up and walking, so she didn't walk till post-op day 1, and finally went home on post-operative day 3. But as you'll see, this was actually our longest admission of the case series. So our second patient was a 17-year-old gentleman who had both flexible thoracic and lumbar curves. Here you can see here's his preoperative films with Dr. Macharo here in the background. And we were able to give him a relatively decent correction with good shoulder alignment at the end. Again, he was up walking post-operative day 0 and home with his family post-operative day 2. And you'll see the common trend for the next 2 cases. This was also a 19-year-old who had relatively flexible curve here. And we were able to align her coronal balance, and we expected thoracic kyphosis following derotation here. And again, she was also up walking within 1 day in the ICU. And then finally, this was our last case of the week. This was a 16-year-old female with a flexible curve, Lenke 1, who her thoracic curve corrected all the way down to 18 degrees. And so we were able to perform just a small segment thoracic fusion, T6 to L2 here, and she did great. She went home also on post-operative day 2. So I mentioned earlier that we only did straightforward AIS cases, and this was for a couple of reasons, but mainly, when you start a program like this, you want to make sure you have fantastic outcomes, that these were all healthy children, no comorbidities. And also we wanted to have local surgeons like Dr. Macharo, Dr. Masawi, really take a lead in these cases. And so in terms of the next step, so the rightful question is, what do you do with all these kids with congenital neuromuscular scoliosis who you just can't treat when you can't do things like high-grade osteotomies, et cetera? And so to treat these kids, really, we had to break this into 2 sessions. And so this past fall, Dr. Ahmed worked with the local surgeons to place craniopelvic halo traction on selected cases where these kids really need long-term traction prior to surgical correction. And then in a couple weeks, we're coming back to Dar es Salaam to provide the definitive correction for these congenital neuromuscular cases, as well as do AIS cases. So we're doubling the practice. We'll have 2 busy rooms with 2 separate surgical teams, where one room will be a congenital neuromuscular room, and the other will be performing AIS cases similarly to what we did during last spring. And so just to paint a picture for what some of these cases look like, here's a 15-year-old gentleman. Pre-traction, you could see a 100-degree curve, semi-rigid, but as you can see here with traction, he really is able to straighten up. And so this is the difference between this case and this case is, with this case, you're able to do the adequate correction without high-grade osteotomies, which in a center where you really can't have blood transfusions, no cell saver, et cetera. It makes a total difference in terms of getting this kid safely off the table and doing a surgery that will be very successful. Here's a 14-year-old female, kind of similar situation, a relatively rigid thoracic curve with a flexible lumbar curve. And with traction, you can really see how her lumbar spine is able to straighten out. So she's one of the cases we have on for next month. Here's a case of a young girl, 10 years old, with neurofibromatosis. You can see the axillary freckling here if you look close enough. And so she has severe rotation, over 100-degree curve here. And then in traction, we were actually able to get a decent correction, and we're going to be able to perform the definitive surgery that this girl needs and hopefully really help her out. And then finally here, just one more case demonstrating the impact that traction has had on these children. Now, unfortunately, as expected, not every case goes as planned. I wish I could show you that traction works perfectly for all these kids, but you unfortunately have situations like this where you have a gentleman here with 15-year-old kid with severe scoliosis. You can see the widened AP thoracic diameter here. Pre-traction, you can see the really diminished lung fields was starting to have respiratory symptoms, et cetera. And unfortunately, this kid really needs correction of his deformity. However, after placing halo traction, he developed mesenteric syndrome, specifically SMA, and so traction had to be stopped. And unfortunately, just due to his underlying malnourishment, he developed refeeding syndrome as a result of this. And so he has not been able to tolerate the traction needed to correct his deformity prior to surgical correction. So I want to finish off by just offering some departing lessons, and this is especially toward the residents, to really take an opportunity like this when it presents itself, and just the amazing things you can learn from an opportunity like this. I think the biggest thing is to understand your limitations, set expectations. As Henry Marsh would always say, first do no harm. I think this is something that Dr. Ahmed and Dr. Balsano have really imparted on me, that when you go in, do surgeries you know you're going to do perfectly. Cherry pick your cases, do the cases that there's no question are going to be excellent, instill confidence in the local surgeons, the local community, and instill trust in them, in yourself from them, that you're going to do a good job. It's really important not to overpromise and underdeliver. It's incredibly hard turning a child away from clinic who you know they're not going to do well, but understand that you currently are limited by the resources you have and that you can't safely help this child. One of my favorite quotes is "Be like water" from Bruce Lee. And I think this is something in terms of learning how to adapt to a culture and not come in as the New York City neurosurgeon or the Italian neurosurgeon and think that you're going to establish your practice in Tanzania as it was in your hometown, and really learning how to adapt to this. Anticipating failure is so important. I truly became a better surgeon in just a week in Dar es Salaam than any short other period that I have in my training so far, and learning how to be comfortable with plan D or E, F, or G, because failures will happen, and if it's going to go wrong, it probably will. It's very cliche, but teaching a man to fish will keep the community fed. And this is something that I'm most proud of, with this opportunity of interacting on a weekly basis with guys like Anas Masawi and Bryson Macharo and Dr. Sharima, and seeing how these guys have really established their practice. It makes me so happy when they send me the cases that they're doing, and I see the post-op films, and they're doing these cases all on their own. The gratitude is immeasurable. And then finally, never underestimate the power of knowledge sharing. This is something that I feel like Dr. Hartle has really been an expert on, of taking a community like Dar es Salaam, Tanzania, and establishing a fully fledged neurosurgical practice there, and now is doing complex cases like complex skull-based approaches. They're doing scoliosis corrections, et cetera. And this is all through articulating your results, being open and honest with the community, and really instilling trust in the local culture. So finally, I just want to acknowledge first and foremost the department who was able to provide me with funding last year to make this trip possible. Dr. Hartle, Dr. Ahmed, and Balsano for their unrelenting mentorship, for giving me trust in helping participate in these surgeries, and for not only learning but teaching at the same time, which is really an incredible opportunity. Globus Medical, who is our instrumentation company, provided us all the instrumentation for the cases last year. And then last but definitely not least, the amazing people at Muambili for taking us in, treating us as part of their family, and really helping, instilling trust in us to establish this as part of their culture now. So I'd like to finish by saying, Asante, thank you so much for the opportunity, and I can't wait to go back in 2 years, or in 2 weeks. I apologize.
Alex, that was magnificent. I think that we all owe you a debt of gratitude to be such a good mentee, and then translate what you've learned to the rest of us. But really, the towering figure here is Roger Hartle, as you mentioned. And Roger is here today. Really would love you to comment, Roger. And one of the questions I have for you is, working at one of the world's great places, why did you embark on this? What is it that motivated you to do this and motivates you to continue this effort, which we all respect?
Well, Josh, thank you so much. Thanks everyone for your kind words. And Alex, that was an amazing presentation, and I really cannot take the credit for this. Of course, I always had an interest in global health, and as a medical student, I spent some time in Africa, and that really left me with a lasting impression. I was always trying to figure out how can I incorporate that into my practice as a neurosurgeon, and it was 15 years ago when I went back there and was able then to establish a relationship. But I don't know. I was always interested. I like traveling, of course, as many of us, and I love teaching and training, and that seemed to be a great opportunity to give back. And then it's really based on the people that you work with. I mean, this as Alex mentioned many times, you need champion surgeons or individuals that you really connect with. And that's the case in Tanzania. Those are amazing surgeons. There's a lot of talent there, and that really motivated me and kept on motivating me until today. Frankly, I never thought that scoliosis surgery would really be a priority. I was always interested in head trauma and head injury, of course, and spinal trauma. But what I have to really point out here is with Dr. Ahmed and Massimo Balsano from Italy and Palestine, respectively, their endurance and their vision, because it turns out that for these hospitals, and that's really a lesson to be learned. I thought trauma was like the big thing in those countries, but scoliosis surgery is actually a big problem for them, because they send a lot of these patients to India, to Europe for expensive surgeries. So if you teach and train them to keep patients locally there, that has a huge impact on the local healthcare structure and economy. So don't underestimate that. Of course, it is important to take care of trauma, but these kind of more sophisticated surgeries sometimes have a huge impact if you can keep them in the local countries. And I think that's certainly the lesson that I've learned through Massimo and through Allah. And I cannot really overestimate the impact that those two individuals really have had on this program. So thank you, Josh, for your kind words, and Alex for a fantastic presentation. But the thank really for the scoliosis part, it really goes to Allah and Massimo and the local surgeons in Tanzania.
Thank you. It's great to see you, Dr. Ahmed and Balsano. Thank you for joining us. There's so many people here in the audience who have massive experience. I see Dick Wynn is on. But we have a really exciting presentation coming up from Dr. Icahn. So I think we probably should move on. Alex, thank you for this.
Thank you.
Thank you.
Thank you, everyone. So next up, we have Dr. Icahn, who